Hello and welcome everyone to this evening's RFC Presents talk. I'm John Spires, I'm the Chief Executive of the Royal Free Charity, and this event is part of a series of talks hosted by the charity to shine a light on our incredible experts who lead pioneering work at the Royal Free London, from cutting-edge research through to clinical innovations. This series of talks reflects for us the strong partnership between the charity and the three hospitals that make up the Royal Free London. Together, we develop and support high-impact projects in our hospitals, supporting staff at every level and investing in the physical and the technical infrastructure, which in turn helps to make care safer, more efficient, more effective and closer to home. We're also proudly looking to the future by funding life-saving and life-changing research to find cures and new treatments for conditions like diabetes, amyloidosis, pancreatic cancer and haemophilia. And of course, none of that would be possible without the incredible generosity of our donors and the tireless enthusiasm of our volunteers, who every day are helping the Royal Free London go beyond the limitations of NHS funding so that we can meet our joint clinical and research ambitions together. Many of you watching today will have supported the Royal Free Charity by giving your time, giving money, or advocating on our behalf, and I want to take the opportunity to thank you all for that. It really is only with you behind us that we can make this possible. In a moment, you'll hear the latest in our exciting series of talks from Professor Margaret Johnson, who's pioneered the improvement of care for people living with HIV. She also incidentally played a big part in getting off the ground the idea of a new home for research in Hampstead, the Pears Building, which the Royal Free has raised money for and which will open in just a few weeks' time. But it's her enormous contribution to the care of people with HIV that she's here to talk about this evening. But before we begin, let me very briefly explain tonight's format. After the talk, you'll have the opportunity to take part in a Q&A. Those of you who have joined us through Zoom can type questions in the Q&A box that you should be able to see at the bottom, and you can do that at any point during the talk. And if you're joining us through YouTube, you can post comments on that page, and my team will pass those questions through to me. I'll do my best to ask as many questions as I possibly can, so please do get involved. We're also recording this event and we'll be posting it on our RFC Presents YouTube channel, where you can also find recordings of all of the earlier events in this series. If you enjoy tonight's discussion, I do encourage you to share that recording with others. But now to the main point of this evening. Professor Margaret Johnson, a consultant physician in HIV medicine at the Royal Free London and Professor of Medicine at UCL, was also an advisor on the highly acclaimed Channel 4 series It's a Sin, which recreated a world gripped by fear and ignorance in the earliest days of the HIV/AIDS epidemic. Without further ado, it's my absolute pleasure to hand over to Professor Margaret Johnson. Margaret, over to you.
John, thank you for that very kind introduction. So I must say, I hesitated a little bit to actually watch It's a Sin. It probably took me about 10 days, after the first episode to actually go back and watch it, simply and solely because it's just thinking back to those times is really quite painful in some ways. And I think that every HIV doctor in the UK will have watched that and thought, those are my patients. I've got a Jill. I've got 5 patients exactly like that. And I think just really thinking back when I was appointed, so I was actually the first physician in the UK to be appointed specifically to look after patients with HIV and to develop an HIV service from scratch. And it was based on the fact that the patients with haemophilia in our haemophilia centre, the majority of those with severe haemophilia all were infected. And I think that, they were very, used to being looked after in the main, part of the hospital. They had all their links with all the specialist services that they needed, but we didn't really have a sexual health team that did any inpatient care. And that was the reason for the Royal Free deciding to make an appointment. I have to say, just as in a way, what was happening in those times, I mean, the 2 people who were my referees said, what on earth are you doing, going for that job? You haven't got any beds, you haven't got any service. And they were quite right. I was appointed and I didn't have an office. I was supposed to have half a junior doctor, but actually that had been given to someone else by the time I arrived. But it was the most enormous opportunity because I had to start from scratch. So I didn't inherit a service that didn't really work. I was able to grow that service to the needs of the patients. But I have to say they were, very grim times for, many patients with HIV. So many of them died in silence and fear. HIV was stigmatized in a way coronavirus, absolutely it isn't. And men would die in hospital alone, and, that they would absolutely plead that they didn't want HIV on the death certificate. They didn't want us to talk to their relatives about it. They didn't want us even to talk to close friends. So I think, that's some of my, sort of recollections of the time. And I think that, after people died, relatives or, ex-partners would come and say to me, did X die of HIV? And, I'd been sworn to secrecy and not to divulge what had been wrong. I think, though, that in some ways it was a time when research became a really very important part of patient care. So a very large proportion of my patients took part in those very early antiretroviral treatment studies. And they would start on monotherapy, they'd then go on to better treatments, so get dual therapy, and then go on to triple therapy. And 10 years later, they were on effective antiretroviral therapy, and their lives started for many to get back to normal. But I think it really emphasizes the importance of research in terms of patients accessing, proper care. So I think that's a little bit of a background of where HIV was then. In the clinic at that time, 10% of my patients every year would die. And things only really changed in 1995 when there were the first trials where there was effective triple antiretroviral therapy became available. So I'm going to now talk about how HIV has changed since then. So if I could have the first slide, please. So the next one. So HIV is not an epidemic that has gone away. Currently, there are 38 million people living with HIV worldwide. 7.1 million of those are unaware of their status. Only 15 of the 38 million, so less than half, are on treatment and are not suppressed. And I'll come to explain why that is an issue. There are 1.7 new infections in 2019, which was from the last report from UNAIDS. And in 2019, 690,000 people died from AIDS-related illness. And progress towards lowering HIV incidence worldwide is stalling. And I think that is, no longer in the headlines and is not necessarily seen as a high priority. So if I can have the next slide. But actually, in the UK, we're doing rather better. So if we look at the number of new HIV diagnoses in the UK between 2010 and 2019, you can see that in all risk groups, there is a decline, but there is particularly sharp decline among sex between men, and that decline is particularly seen in gay men living in London. Can I have the next slide? Now, if you do a back calculation from the CD4 count, which is the immune marker that we use to identify the severity of disease, what you can see is that actually we think that the incidence has probably fallen by 70% over this period of time. Next slide, please. So in the UK, in terms of diagnosed and undiagnosed infections, what you can see is that the majority of people living with HIV in the UK are aware of their infection. And you can see that really across all risk groups, but particularly among gay and bisexual men. Now, from the time of infection to developing AIDS, that we know from before antiretroviral therapy, the average time was 10 years. So actually, many patients during that time were completely well, and therefore that undiagnosed population, unless they are aware that they've been at risk or that this is identified by their clinician, they may go undiagnosed. So can I have the next slide? So a big issue for HIV diagnosis is late presentation. And if you look here among the proportion of patients who present with a CD4 of less than 350, and we know that patients who are diagnosed with a CD4 less than that have a reduced life expectancy, have more AIDS-related events and other significant problems. And what we see is that still in the UK in 2019, over 35% of patients in all of the exposure groups were diagnosed late. So we still have a problem. It's getting better, but we still do have too many patients presenting too late. Can I have the next slide? So once patients are diagnosed, and it means they get access to antiretroviral therapy. And the goal of therapy is to drive their plasma viral load to undetectable levels. And in the UK, we are doing really well from that point of view. UNAIDS have given a target that 90% of patients who are on medication should be undetectable. And across all exposure groups, ethnicities, gender, and region, we are well above that 90%, apart from in the young age group, those between 15 and 24. Can I have the next slide? So, so what's been the game changer in terms of and HIV management? And this, of course, is antiretroviral therapy. So this reduces, so if we just go through what are the benefits of antiretroviral therapy, they stop patients from getting ill. So they reduce mortality, they reduce maternal mortality in women that are pregnant, they prevent mother-to-child transmission, they reduce the number of children becoming orphans by losing their parents, they prevent HIV transmission among serodiscordant couples, they restore employment, it leads to respect and dignity for people living with HIV to be undetectable. It's very important in terms of post-exposure prophylaxis for people exposed to HIV, and very importantly, its role in preventing HIV transmission in serodiscordant couples, as well as preventing mother-to-child transmission. So antiretroviral therapy has been a real game changer in the management of HIV. Can I have the next slide? And HIV treatment has improved dramatically. If we look back to the 1980s, when triple therapy first became available, it was very frequent that patients would be taking 20 pills a day. They would be taking drugs either, three or four different times during the day. And that clearly led to adherence problems and also toxicities. And this has really been revolutionized over the last 20 years. In 2018, we started to have a number of single tablet regimens that were well tolerated and had reduced toxicities. Can I have the next slide? So what are the benefits of antiretroviral therapy? Why is it so important that we diagnose patients early? Certainly from the point of view of the individual, it has a major impact on life expectancy and it reduces morbidity. From the point of view of the population, it reduces healthcare costs and it reduces transmission. And I think what is also incredibly important is that it's very important for the individual to have the confidence that their HIV is under control, that their viral load is undetectable, and therefore they can't transmit infection to those who they are in relationships with, or a mother who's pregnant won't transmit HIV to their baby. Can I have the next slide? So coming back to UNAIDS, they propose that we should be trying to target across the world 90-90-90 treatment for all. So of the 38 million people living with HIV, we know that 87% know they are HIV positive. 2 out of 3 living with HIV are on antiretroviral therapy. So only 59% of people with HIV have an undetectable viral load of the virus. So as you can see, 41% of people living with HIV in the world today are not on adequate therapy. And I have the next slide. So how are we doing in the UK? So this is looking at that 90-90-90 target. Of the people living with HIV, the 105,000 people living with HIV in the UK, 94% are diagnosed. Of those that are diagnosed in the UK, 98% are on treatment. And in those that are on treatment, 97% have an undetectable viral load. But if you look in terms of the totality of patients living with HIV in the UK, only 73% of patients reach that UNAIDS target. Our figures at the Royal Free in terms of viral suppressed, we meet all those targets, but of course, like the rest of the UK, it's that proportion of people who are diagnosed late that we still are not getting optimal treatment for. Can I have the next slide? So what has all of this done for the life expectancy for a patient with HIV? So this is a study published back in 2016 that looked at an average man of 25 with HIV in a population where the average life expectancy was 80 years. If the patient was diagnosed in 1995, 96, so immediately prior to the availability of effective antiretroviral therapy, the likelihood is that 25-year-old man would die age 34. Now, with proper antiretroviral therapy, the life expectancy for that man would be 73.9 years. And there's some data to suggest that it may be even better because patients with HIV have regular medical follow-up. So those that are engaged with care and are on antiretroviral therapy and are adherent to that and have their general medical needs managed have an even better life expectancy. So can I have the next slide? Unfortunately, though, HIV comes with a number of comorbidities, and these include an increased risk of non-HIV related cancers, cardiovascular disease, chronic kidney disease, hypertension, and diabetes. And all of these things interact. And in addition to that, there are lifestyle issues around smoking, alcohol, and mental health issues. And Obviously, there's things that we can't change in terms of medical care. We can't change people's age, ethnicity, or family history, but we also do need with our patients to try to manage those things that we can change. So stopping smoking, sensible alcohol use, optimizing weight, encouraging exercise, treating high blood pressure, treating abnormal lipids, and getting support around substance abuse and mental health and social isolation. So can I have the next slide? So comorbidities are more prevalent in our patient population. In this study, it looked at cohort that compared an HIV positive population with an age-matched HIV negative population. And as you can see, that our patients are much more likely to have more comorbidities. We see raised rates of hypertension, cardiovascular disease, peripheral vascular disease, impaired renal function, and as I said, a number of non-AIDS related cancers. The next slide. So coming to what are also very important in our patient population is the prevalence of mental health conditions. And this is from the stigma survey, which is collected via Public Health England from 33 clinics in the UK. And if we look at our patient population at the Royal Free, that 19% of people in the general population have depression. 33% of people with HIV nationally have depression, and our patient population has a slightly higher proportion at 38%. Our patient population has a slightly higher rate of anxiety, 25% in HIV nationally, but 15% in the general population. And also with insomnia. Now, you may ask, why is that the case? I think first and foremost, that our patient population tends to be those patients with comorbidities. And that is because, as I said, we were able to establish a clinic that really met all of the needs of patients in terms of their general health. We have very close relationship with our liaison psychiatry service, and we also have a very important clinical psychology service. And I think that that's a reflection in the slightly higher rate of anxiety, depression, and sleep disorders in our patient population. Next slide. In terms of disclosure and discrimination, I think that this slide from the same survey absolutely highlights that the issues that we talked about from the early days haven't gone away. So if you look at patients' disclosure outside of healthcare, 9% of patients at the Royal Free have disclosed to nobody. 69% to friends, only 62% to a member of their family, 68% to sexual partners, and 26% to other people. In terms of discrimination in healthcare, which was in many ways a very important issue in the very early days. I mean, I used to battle to find, colleagues who would be, keen to get involved with the management of patients with HIV. I had to really really go and look for colleagues who would be interested, and actually once they became involved in the care of patients, really became very passionate in championing care for them too. When we asked patients in the survey in the past year, because of your HIV, have you worried about being discriminated against in the healthcare setting? 13% said they had. That was lower than the national average, which was 16%. We also had a lower percentage of those who said that they avoided seeking healthcare when they needed it. That was 10% in the whole national figures. And in terms of the number who actually had been refused or delayed a treatment or medical procedure, that was 6% in our patient population and 5% nationally. So can I have the next slide? So where do I think we are today, and what do I think we've achieved? So I think we've achieved an enormous improvement in life expectancy for people living with HIV, and hopefully that will continue to improve. I think that knowing that antiretroviral therapy means that if a patient is on treatment and undetectable, they are not going to transmit HIV to a partner or to a mother to their baby. And this is real empowerment for our patients, and I think has been truly transformational in their quality of life. I think that we've had new medicines that are much easier to take. There was much less drug toxicity than there was in the past. We're also going to be seeing new modes or new drugs coming along that will be long-acting, that can be injected. We may be seeing patients increasingly on 8-weekly injections of treatment, and that will be a choice that some patients will choose. Other patients will prefer to continue to take a tablet on a regular basis. Have we got to the stage where we should be? And I think the answer, and I hope that I've shown you, is unfortunately no. I think that we certainly, if you ask patients what is the most important thing they would hope for in the coming year, 5 years, 10 years, it certainly will be HIV cure. And I think that, hopefully given, the focus on antiretrovirals, treatment of viral infection, and that increased investment in that, hopefully HIV cure will become a bigger focus. I think the prevention increasingly has, but still needs to have a more central role in HIV research. I think there is some optimism that the mRNA viral vaccines, this may be technology that may be helpful in terms of HIV. There's a study opening in Oxford imminently, and I think Moderna have 2 studies looking at an mRNA vaccine for HIV starting in the US in the near future. I think that we also need to relook at how COVID has impacted on delivery of HIV care over the last year. I think that we need to think about, we mustn't lose the holistic care that this patient group needs. I think that we need to, to structure services to meet the future, needs of patients very much around the comorbidities of our aging population. And we also need to reflect and see the impact of HIV on COVID outcomes in terms of there is at the moment limited data, but it does seem that patients with HIV, particularly those who are don't have an undetectable viral load and have a low CD4 count, probably have a worse outcome if they get serious COVID. And also we need to look at the impact of COVID vaccines on a population of patients with immunosuppression. And in my final slide, I want to finish by what I thought was a very powerful quote from Anthony Fauci, who I think you'll all know is the Chief Medical Officer in the US, who is our Chris Whitty, who earlier this year said, "So why does this global pandemic continue to rage? It's not that we lack the medical advances and the interventions to end the pandemic. It is that our proven tools have not been implemented adequately or uniformly. And I just want to go back to the fact that we still have 38 million patients with HIV, 15 million of those patients know about their status but aren't suppressed, and there were 690,000 people who died of AIDS-related illnesses in the last year that we have numbers. So this is an infection that we still need to have major focus on. So thank you.
Thank you very much indeed, Margaret. Now, I'm going to ask, just before we go into the Q&A, I'm going to give you an opportunity to take a breath, and I'll give our viewers an opportunity to ask questions through the Q&A function or through the chat. And we've had a question, first of all, from Carl Margaret, who says, thank you very much for this presentation. Understanding a little about how the virus works and functions and can lie dormant, is a cure for HIV something we really can look forward to or expect?
So, clearly the fact that HIV hides away in reservoirs, so our antiretroviral therapy can suppress the virus in plasma, but certainly, unfortunately, there is still virus hidden away. So I think, the answer is that I would say that I don't think we can expect anything very imminently, but will we actually work this out, and will we actually come up with a cure? I'm sure over the next 10 years that will happen.
Absolutely. And you alluded to that global burden. We've got a question from Monty, who says, research and management of HIV has clearly made enormous progress in the UK and in the developed world, but there is a high burden of undiagnosed and undertreated HIV and AIDS in those middle and low income countries that you were talking about. So, for example, the recent outbreak in Pakistan amongst children. Do you think post-COVID we need to encourage more outreach programs to educate and support and fund those patients who are also very much in need?
Absolutely. And, clearly, education, sharing management, between countries is incredibly important. But I can tell you, actually, one of the countries that has a, very low rate of undetectability is the US. So it's not actually only in underdeveloped countries that, there is a problem. So I think that, yes, I think we absolutely should be sharing whatever we can. I think that the great burden of infection is indeed in middle and low-income countries, but outreach programs to educate definitely are very important.
And you talked, Margaret, about those early days and the challenges that you had encouraging colleagues to support you. And indeed, you were obviously an absolute pioneer yourself in making the decision to move into HIV. I think we probably, those of us who saw It's a Sin, sort of recognized those that enormous stigma that people experience, the challenges that in asking for help and receiving help. And Anthony's asked a question about whether hospital chaplains were ever reluctant to visit HIV patients, and perhaps it might be instructive and informative to sort of understand the challenges you had encouraging colleagues to take part in the support of those patients, and how that might have how that affected you and how that might have affected those patients themselves.
So, I mean, what I would say is, no, I don't ever remember there being an issue with hospital chaplains. I certainly did have problems with colleagues who would, very much say, well, the patient's got AIDS, he's going to die. I don't see why we would want to do this procedure. Or I need to have full PPE, but full PPE was, of a level that, you wouldn't in any way have any way of getting hold of at that time. So, there was a lot of reluctance to get involved in managing the patients. Having said that, on the other hand, having sought people out and identified a group of clinicians who supported what is a very complex multi-system, medical problem. Actually, we became a very tight-knit group, and they all became, incredibly supportive. And I think, research was also really a real driver around that. We were constantly getting patients into clinical trials. We put, the first patients in from the Royal Free went into the, the very pivotal phase 3 studies. And you could see that patients were benefiting from that. And it was so, I think people genuinely wanted to be part of it.
Of course, and I think we talk all the time, don't we, within the Royal Free London about the importance of that read across between the research that we do and the clinical excellence within our services. So HIV, I think, a fantastic example of just how useful it is to be able to combine research and care. On the research point, actually,
one other thing around that time, and I think that I was really lucky in the management team at the Royal Free at the time. So if you come to the Ian Charleston Centre, it's opposite the library. It's in the main bit of the hospital. Most patients with HIV at that time had to go to GU clinics, which were hidden behind the back of the hospital in a hut. And it was a really strong message. And it might have been because we have this hemophilia cohort, but we actually, have a clinic that is absolutely center of the hospital and it always has been, very visible, not something that was hidden away. And I think that gave a very strong signal that this is a medical problem like any other.
Absolutely. We've got a couple of questions I'll combine actually around collaboration in research. So one question from Judy asking whether pharma companies collaborate on HIV research or whether that needs to be encouraged more. And someone else asking a related question, do you think that the scientific collaborations that brought, for example, the COVID vaccines, do you think that sense of collaboration is something that can support us in the hunt for an HIV vaccine? So I guess a couple of questions around whether or not we're seeing enough collaborative effort between pharma companies and researchers to drive HIV forwards.
So I think that in terms of collaboration, I think there was enormous collaboration in the early days. No company had the 3-drug regimen, all 3 drugs in one company. So there had to be collaboration, and that did drive that to happen. I think maybe they're more competitive now because we really do have drugs that work. Having said that, there are a small number of patients that I look after who've been positive for 30 years. They have multi-drug resistance and they need treatment. And they are very, very small numbers of patients. But actually getting collaboration for those patients sometimes is more difficult. So in terms of vaccines, I think, I think there's a real opportunity now. I think, mRNA vaccines, very clearly, may be the way forward. And I think that it's very exciting, very hot on, the vaccines for COVID, that those studies are, planned and opening.
Absolutely. And the pairs building, which we touched on at the very beginning of the talk, obviously the part of the reason for building the pairs building was to increase our ability to support research into immunity and into transplantation as well. And there will be work on COVID in that building, but also there'll be work on HIV. I wonder if you can touch on the sorts of things you think we might be able to work on now that we have that new building almost open.
So I think first would be, what about how effective are COVID vaccines in the HIV population? So you have a population that, clearly still has some immunosuppression. I think that, will our patients need to have, more than 2 vaccines? Will they have to have a higher dose? Are they going to get the same immune response as someone who's HIV negative? Do we just have to worry about those that are immunosuppressed and have low CD4 counts? There is a group of patients who are diagnosed late, have low CD4 counts, and they don't get immune reconstitution to the same degree as others. So, that would be one question that I think is a really important one, and one that we can, we can quickly answer.
Super. We've got a question from Mo. I'm sure this is one you're asked a lot. There have been reported cases of HIV cure, one in Berlin, I think, and possibly another one in London. I think these might be the references to the the people that had stem cell transplants, I
Exactly.
think, but you're the expert rather than me. How true are those reports, and what can we take from those reports, do you think?
So I think the answer is yes, for those individual patients who have leukemia and need to have a stem cell transplant, that was, really, an added bonus for them in terms of their response then to their underlying problem. But, this stem cell transplants is not the way to manage HIV. HIV for almost every patient is manageable with antiretroviral therapy. Much easier, much less mortality associated with taking HIV medicines rather than a stem cell transplant.
We've got a question from one of our Zoom attendees saying, if there was one thing that you could change today about HIV treatment and support, what would that change be?
So I think that change would be very much around, we have an aging population with HIV. We know they have more comorbidities. What patients really don't want is that they come to me for their HIV. I have to send them to someone else for their cardiovascular problems, for their renal problems, and then they have to go and see someone because they've got a problem with their bowels. They want to go to one doctor and get most of their care managed by that doctor, and obviously having access if they have something super specialist. So I think it's bringing general medicine and holistic care to patients. So an HIV doctor should be able to manage and to prescribe, all of the medications that patients need.
Absolutely. Great question here from James. If you could go back to the 80s, what would you do differently as a result of what you now know?
What would I do differently? So I think I probably I should have shouted louder about testing. I think that there was a real reluctance around clinicians offering, testing. I think there was also a whole area around, in a way I'm not sure I did, but there was a whole bunch of people in HIV who really were the guard dog of the patient. So, encouraging that, in order to do an HIV test, this was different to any other test. And that, there was, what about, all of the stigma that would, result in. And I think that led to a lot of patients not getting tested, diagnosed late, and dying because of that. So I think that, however much I was always, an advocate for testing, I think maybe I should have made even more of a fuss, made more noise around that at the time. I mean, antenatal testing was an example. I sat on the expert advisory group on AIDS for many years. And I remember having these arguments around the table in that the lawyers and the Department of Health people would say, well, that we shouldn't be testing people antenatally. That's going to, really be, such a problem for the pregnant woman getting that, result in pregnancy. Well, the bottom line is much better to get the result in pregnancy rather than when your baby is dying 3 weeks old of pneumocystis pneumonia and on a ventilator.
Mm-hmm. And I guess that question also sort of reminds us about It's a Sin, which you of course were an advisor on. How did it feel for you to be seeing that story told again, and to I think a very large audience, because the program was obviously enormously popular as well? What was your experience of advising them and then seeing the public response to the program?
So I think that it was, I think it was a really important program to show, and I think that it does show how we've come a long way since those dark days. I think that, my feeling of it was I looked at those five people, and I sort of could see my patients in it. I could see my Jill, I think, actually the warmth of how, that group of friends really cared about each other. And I remember so much of that. I also remember, other patients who really were totally alone. And, when I never had the problem that we saw when people were locked in rooms. I mean, that never happened at the Royal Free, thank God.
Yeah, yeah.
So I probably, I didn't actually sort of get involved until the later 80s. So I think in the early 80s, there may have been more of that, but certainly by the time I was appointed, that it's slightly moved on. There was still lots of stigma, and there was, all the things that we've talked about.
Yeah, absolutely. And you've talked about the the stigma, and you've talked about the some of those people, of course, who had no support. Today, I mean, I guess you've alluded already to the Ian Charleson Day Centre. How important is it when someone's diagnosed, and it, particularly in those earliest, most difficult days, how important is it for them to recognise that there are others like them who they can access through places like the Ian Charleson Centre? Is peer support something that is?
I think peer support has been a real game changer. I mean, to be able to talk to somebody who's been through the same experiences that you've been through, to be able to talk about, the big issues that, that confront people with HIV. I have patients who, are on treatment, they're undetectable, they've met a new partner. What are they going to do? Do they have to tell them? I mean, if they're undetectable and taking their treatment, I'm not sure they do. And how people are coping with lives today. Mm-hmm. So I think it's very important, so a pregnant mother, how am I going to manage? I don't want to breastfeed because I know there might be a small risk of transmission. I am going to be taking my pills. I don't mind being monitored. I am going to be having my mother-in-law who's going to be saying, why aren't you breastfeeding? Mm-hmm. And actually talking to another mother, another patient who's been through a similar experience is really helpful. Yep. So I think peer support, and I think peer support actually across medicine is becoming increasingly important.
Yes, yeah, I couldn't agree more. We've had a question from Virginia, who's watching on YouTube, asking about elite controllers. So I think you might need to explain that term for the rest of the audience. But what's your take on the evidence around elite controllers?
So there are a very small group of patients who are elite controllers. There is a patient in the haemophilia cohort from the Royal Free. Now that was a really important cohort because, as I told you, that all of the severe haemophiliacs were infected. And actually, the haemophilia cohort patients had participated in hepatitis B vaccine trials. So there were stored samples in the freezer. So it was possible to test their blood and actually identify it exactly within a 3-month period when they became infected. And that cohort has been really important in terms of mapping out the natural history of HIV and a real strength of our epidemiologists here on the Royal Free campus. And there's one patient that I still look after, and it is 37 years later, I think, and he still has a normal CD4 count, has an undetectable viral load, and has never had treatment.
Gosh, wow. Superb. You alluded earlier to the...
And they've always been a group that we've sort of felt should give us the answer.
Yes.
It hasn't happened yet.
Yeah.
And there are so few of them, it's so difficult for there to be a big cohort of them.
Of course. Yeah. We've touched on COVID a little, and I think it's obviously something in people's minds. Do you think there are any lessons we can apply to what we might be facing now, to the where the pandemic looks like it's heading now? Do you think there are any lessons that we've learned from the approach we took to HIV/AIDS, which would, perhaps are not so well known outside of your world, that you think would be useful for researchers, perhaps, or clinicians, or just the wider public to think about?
So listen, I think actually, from a sort of a research point of view, I mean, COVID has been a real triumph for the UK. I mean, and Tony Fauci, who I quoted, as to, we should be doing things differently around HIV. I mean, he is on the record in the New England Journal saying, that the UK's played a blinder. I mean, the recovery trial is second to none. REMAP cap, okay, fine, dexamethasone is the real positive. Tocilizumab, also given at the right time is a positive, but also it's actually shown all the things that don't work. That we're giving patients toxicities. And the key to me is that the reason my patients survived is they went into clinical trials. And I've many patients who've been into 9 successive clinical trials, and they'll actually come and say, what can I do next? And, I think, the key for COVID is exactly the same. We must put patients into clinical trials, and those clinical trials, will give us the negatives as well as the positives.
Well said. Thank you very much indeed. Margaret mentioned the Ian Charleston Day Centre a couple of times during her talk, and I just wanted to mention to those of you who are interested that we are running a fundraising appeal to mark the 30th anniversary of that incredible centre. They've raised an impressive £20,000 already, and a very generous supporter of the Royal Free Charity has agreed to match the next £10,000 that we raise. So you can see the the Just Giving page here. If you Google ICDC 30th anniversary, you should find that very easily, and we'll have a link on a slide at the end. If you want to help the charity support the work of our hospitals more generally, we'll shortly have a slide with some links on that. We simply wouldn't exist without our supporters who give their money, their time and their energy to enable our work in partnership with our NHS colleagues at the Royal Free London. We have huge ambitions for the coming year and the years ahead as the Trust restores its full complement of services in the wake of COVID and looks at the lessons that we can take from this extraordinary situation to improve care for patients. All sorts of different ways that you can help, from giving a personal donation to being sponsored to take on a challenge or giving your time as a volunteer in the hospitals themselves. If you'd like to help, our contact details will be on the screen at the end of this event, or you can look at the Royal Free Charity website. I want to flag 2 more dates for your diary as well. The next RFC Presents event will be on the 24th of May, and that will feature the health policy expert, Professor Sir Chris Ham, who is also a non-executive director of the Royal Free London. And on the 21st of June, we'll have Karen Turner, who's a senior improvement advisor at the Royal Free Hospital. I want to say an enormous thank you to everyone who's joined us this evening, to my team working extremely hard behind the scenes for making tonight happen, and of course to Professor Johnson for a fascinating and inspiring talk. We look forward to welcoming you all again to another RFC Presents talk very, very soon. Thank you very much and good evening.